So when we're putting people on therapy, obviously the standard goal that we all are going to advocate is no seizures, no side effects. But in the real world, that is a little tougher to accomplish. But practically speaking, when you meet with your patients, what are the objectives that you state for them, and how do you take what they tell you into consideration when planning therapy and assessing your therapy?
I think that's a huge important. That's one of the times that I definitely make the time, because it's very important. The person that is being initiated on treatment for epilepsy has very little knowledge about it. So if a parent brings a kid to me and I say, we're going to treat you for the seizures, and I don't explain it further, they expect the seizures will stop with that treatment. And we know the reality of epilepsy depends on the type. The possibilities of seizure freedom may be somewhere between 70% or 80%, whether it's focal or generalized. So we have to tell them that there's a reality, and depends on how much information we have. If we have a healthy, developing brain with a normal MRI, maybe we have a great chance. If we have a very traumatic injury with herpes encephalitis in both parts of the brain, the epileptogenicity may be so abundant that it's hard to fully stop it. But the reality is the goal is always to make someone seizure-free, but it's not always something you can accomplish. And I used to tell my residents, I said, remember that you cannot make everybody seizure-free, but you can make everybody sick. So you have to keep that in mind so that you can actually treat patients to the best possible control.
Yeah, that's my statement to my residents and fellows is that it's very easy to make someone worse. It's a lot harder to make them better. It's the same idea. So yeah, I view one of the main missions is to warn people about potential side effects, not to excess, or else they'll develop them, perhaps, but warn them and really pay careful attention to side effects. But there's also the goal that the patient has too, Kate, and again, treating adults who have a job other than being a student. How do their occupations play a role in this, and when you're gauging treatment and your goals for therapy, and what do you advise people?
Of course, it plays an enormous role. If a patient, for instance, is a high-functioning professional, they're going to have different goals. There'll be different medications that may be more or less appropriate. They may be willing to pay more for a medication that's not as impactful to their cognitive performance, for instance. In adults, often driving is a critical part of their livelihood, and so they are very focused on becoming free of seizures with loss of awareness, and that is a big point of discussion. And then we also have adults that have had epilepsy since early childhood and have severe cognitive impairments, and we could treat them until we harm them, and it's often not the right thing to do, and it's impossible to make them seizure-free. So trying to balance quality of life issues with the danger of seizures is an important part of the decision-making with each individual patient.
Yeah, thanks. The occupational aspects can be especially challenging in people, and I think we don't want to overly restrict them. On the other hand, we want them to be safe, but they are adults, and I think there's certain judgment. I just saw someone yesterday for the first time who naturally is a construction worker. In the summer also does landscaping, so he's using chainsaws and electric hedge clippers. And the goal there, I think, first is safety. Exactly. So there's counseling about occupation. Right,
and working with them perhaps to alter their job to make it safer, at least while you're getting the seizures under control. But that can be a very difficult conversation, because then not only are they frightened from the seizures themselves, but it's threatening their livelihood.
Yeah, I think one other additional point, the safety and adverse effects, obviously a big part of the discussion, but what's come in a lot has been comorbidity issues. So as opposed to often just talking about one anti-epileptic drug, I try not to say there's only one drug you can be on, because if it fails, the patient thinks that now whatever you're giving them is second best. So I tend to talk about a range of different choices that are determined, one by efficacy, one by side effects, and the other is by comorbidity. And I think that's an additional issue that comes up in terms of discussion.
Yeah, and the comorbidities, especially tend to accrue as people age.
Age, right.
So it becomes far more complex.